All right, hello everyone. We continue with our discussion of the pulmonary and critical care system. Okay, so what do you do if you see a patient 55 came in with a productive cough, pleuritic chest pain, and then you end up being intubated, right? They give you a bunch of ventilator setting, and there's some crackles, but the blood pressure is low, right? What do? Blood pressure is like map below 60. Okay, what's best next step? Next step, you want to do norepinephrine infusion. So this is important to know when you start. What pressors? Okay, so this is something you want to do norepinephrine. There are disadvantages for it. It's like this arrhythmia, it could cause this arrhythmia, but usually that's the go-to. Uh, Dopamine as well can cause increases this arrhythmia. If you have somebody tachycardic, have a lot of arrhythmia, you can do phenylephrine, used for septic shock. But decreases planking blood flow, that's a disadvantage. Vasopressin can be augmented with the other pressors as well. Epinephrine has a lot of risk of dysrhythmia as well. Dobutamine can be used, but could cause hypertension as well. Okay, now this is a case of pressors. Now you have this patient, 45, came into the ED with AFib and slow ventricular response. So temperature, what's the temperature? Temperature is 29 cc or 84 Fahrenheit. That's a very low temperature, okay? So this is a very low temperature. So what would you do for this patient who's like hypothermic, okay? So this is management of hypothermia. The treatment for that is a large volume of warm crystalloids, okay? I'm going to give IV fluid. So this is management of hypothermia. There are different types of hypothermia, right? So it could be mild hypothermia causes tachycardia, tachypnea, ataxia, dysarthria, and increased shivering as well. And there's moderate causes bradycardia, lethargy, hypoventilation, and severe you have coma, cardiovascular collapse, and ventricular arrhythmia. So it's interesting, the mild causes tachycardia, but the moderate, the heart would not be able to keep up, so you will have low. Alright, so what do you manage? How do you manage it? You give IV fluid, okay, endotracheal intubation if needed in comatose patients, and rewarming technique. If it's mild, just passive external warming, just remove wet clothing, cover with a blanket. If there's moderate hypothermia, you do active external rewarming, okay, like a blanket or heating pads or warm pad. But if there is severe hypothermia, active internal warming, so you do warmed pleural or peritoneal irrigation and warm dehumidified oxygen. So this one you give warmed crystalloid. So this is because this is a very severe hypothermia, okay? Warmed intravenous fluid, basically. So this is how you save someone's life. Okay, now you have another patient who's 43, had pancreatitis, developed respiratory failure, right? And of course, if you respiratory failure, you need to be intubated, right? Okay, so what is the best next step for this patient? You would do intubation. The way they bring a hypoxia, patient's hypoxia on 50% Veni mask, okay? 86% on 50% Veni mask. So you want to do intubation, okay? Even if you just extubated the patient, still requiring a lot of oxygen, you still intubate them again. So now, what are the signs that means that there is extubation failure? Okay, symptoms of impending respiratory failure. Usually if there is pH less than 7.3 or PaCO2 more than 45, okay? If there is a clinical signs of respiratory failure, if there is respiratory rate more than 25 per minute for 2 hours, or hypoxemia. If there's any of that, that's mean there is a failed extubation, so you can intubate them. And what are the risk factors for extubation? The risk factor that makes it hard for extubation failure Usually any pulmonologist, they have extubation failure, like you extubate and then you re-intubate again. Risk factors is weak cough, frequent suctioning, poor mental status, positive fluid balance 24 hours prior to extubation, pneumonia as initial cause of respiratory failure, age more than 65, comorbid conditions. So all of these things could increase risk for extubation failure, okay? Now we have another case. 73-year-old man comes in with fever, shortness of breath, cough, productive crackles. Okay. So fever, shortness of breath, and crackles, and PaO2 65. What would you do? Chronic low oxygen, acidotic, you know. Then this patient's, what you want to do is you want to intubate. This patient is in a critical condition. You want to intubate, save their life, you know. So what are the... You can do a non-invasive passive ventilation here because the patient is fairly acidotic. Okay, so they want you to choose, would you intubate or you do non-invasive ventilation, okay? Now, there's another patient, they give you a case of ARDS, intubated, decrease the breath sounds in one area, okay? What's best next step? Retract ET tube. This is very important, they test on it a lot. So you gotta know when to recognize it because very easy fix could save someone's life. Okay, so how do you know when there's improper positioning of endotracheal tube? Okay, usually you see asymmetric chest rise. Okay, if there's endotracheal intubation, unequal breath sounds, normal waveform, and then so you reposition the endotracheal tube, confirm placement with physical examination and chest X-ray. Okay. How about there is sometimes the risk of esophageal intubations. Usually you see the abdomen rise, breath sounds, you hear it in the stomach. You hear it in the stomach, that's a risky thing. May have normal waveform in the first few ventilation, then flat line. What you want to do in this case, extubate and re-intubate the patient, okay? Okay, there's another case, you see 28-year-old, came in with shortness of breath, wheezing, okay? What would you do? Like the patients just come in the office, have asthma. What do you manage asthma? You want to do short course steroid or prednisone, like mid-roll pack, and scheduled budesonide for meteral. This is for asthma management question, you know, so you gotta know how to manage asthma. Someone with adult acute asthma exacerbation, you want to treat underlying inflammation to prevent relapse. Oral steroid 5 to 10 days is good. You know, step up therapy for 2 and 4 weeks and then reassess. Which means if somebody on as needed, you could put them on a daily inhaled steroid, beta-2 agonist. If someone already on budesonide for meteral, just increase the dose or add an additional controller agent, okay? This is how you manage asthma, okay? This is the step up, it's called step-up therapy. Basically, everybody asthma need to be on inhaled corticosteroid plus formoterol. You start as needed. If you need it more, if it's less than once a day, if it's like most days, then you just do it daily, low dose. If they still have symptoms, waking up with asthma at night, then you just do it medium to high dose. If they still uncontrolled after even medium to high, you increase the dose to high dose. If still uncontrolled with high dose, you'd add long-acting muscarinic antagonist like Incruz, okay, meclidinium, and you can consider biologic therapy as well, omalizumab, or like difficult to treat. You can add the leukotriene antagonist as well, like montelukast as well, can be helpful as well. So this is for asthma management, something to be aware of, very common, something it's important as well. Okay, now there's an important case, like somebody in the ICU, 65 patients, a year-old, came in the ICU, and still like there's a, so still having agitation, you know. The patient is agitated, grimacing, agitated, you know. Tachycardia, hypertensive. So what would you do? You want to increase fentanyl dose. Make sure their pain is adequately treated and controlled. Okay, if it's not controlled, that's not a good sign. Okay. Other scenarios, you see 63-year-old came in with right pleural effusion. Okay, chest X-ray shows a 20 mm free flowing effusion. What would you do? We discussed if it's more than 10, you do thoracentesis. This is important to do thoracentesis. If it's more than 10 millimeter, or if there's loculation, if there's hemithorax, thickened pleura, you do diagnostic thoracentesis. Okay. You do drainage with fluid analysis if there is loculation, hemithorax, or more than 10 millimeter. If there is none of that, you just do diagnostic thoracentesis. If there is positive blood gram stain or culture or pH less than 7.2, then you do drainage with fluid analysis. You do chest tube. So this is important. Like if it's less than 10 free flowing, then you don't do it. So this is like in a summary. This is when do you do just diagnostic thoracentesis? When you do chest tube. Diagnostic thoracentesis, if the patient has more than 10 millimeter, but there's no loculation, no hemithorax, no thickened pleura, you just do diagnostic. And then you see if the pH is low in diagnostic, gram stain positive, then you do chest tube. But if there's loculation, hemithorax, you start with chest tube right away. Okay, that's kind of the summary for this case. Okay, now they give you another RDS patients intubated, and they're asking you what is the best strategy for this patient, the ARDS patients, like whatever reason, pneumonia, pneumothorax, all kind of cough, shortness of breath symptoms. Okay, so patient ARDS, what is the best? What is our goal? Our goal is to have low tidal volume ventilation. Okay. Now this brings us to the discussion, what are the criteria for acute respiratory distress syndrome? So the criteria for ARDS, if there is a new or worsening respiratory failure during the past week or within 1 week of known clinical insult. Okay, pneumonia and then worsened. Okay, that's one thing. On chest X-ray, you see bilateral lung opacities consistent with pulmonary edema. If there is no signs of cardiac failure or fluid overload, this means it's like a lung issue, not heart. Objective assessment also echo to exclude pulmonary edema in patients without ARDS. And their severity of hypoxemia is defined by pressure of oxygen divided by the fraction of inspired oxygen. Okay, mild is 200 to 300, moderate is 100 to 200, severe is less than 100. That's the criteria for ARDS. It's pretty interesting. Now another question they want you: what is target glucose at the hospital? You want it between 140 180. That would be good target glucose. Okay, and that's something to consider. Target glucose. So stress hyperglycemia, you see transient hyperglycemia, especially patient ICU, patient septic, major trauma, hypoxia. So in this case, you just to give insulin to target 140 to 180 is fine. Okay, minimization of the glucose and IV fluid as well. Try to give them just fluid without the glucose. Okay, this is diabetes management. Alright, now we have another patient came in. So let's review the cases and then we'll go to the next one. So we talked about targeted glucose, talked about low tidal volume ventilation, when do you do thoracentesis versus chest tube, how do you manage pain in comatose and intubated patients. Midroll pack is helpful for asthma. We don't want to intubate if somebody sedemic intubation. Large crystalloid, it's helpful. You want to give norepinephrine infusion for warm crystalloid, warm fluid for hypothermia. Norepinephrine is a really good option for septic management. Okay, and that concludes discussion for this section of the pulmonary system.